you've heard, I'm going to say something about free market healthcare in Australia. And I've interpreted this to mean saying something about the introduction of the National Taxpayer-Funded Health Scheme and the medical profession's approach to it. This will necessarily involve frequent reference to, and almost always uncomplimentary reference to, the role of the Australian Medical Association, which has always been Australia's most dominant medico-political organisation. According to its recently published history, even in the 1930s, the AMA accepted the introduction of a national health scheme as inevitable, and it actually nominated the general principles that it felt should underpin such a scheme. This produced a furious reaction from its members, and the subsequent political row led to shelving of any further proposals. However, this event so early in the story underlined some of the difficulties that have always bedeviled medico-politics. In particular, that those in leadership roles often have political dispositions that differ, and often quite markedly, from those of many of their members. And while often claiming to speak for all of them, they rarely have the moral authority to do so. The AMA's policy, at least in its early years, not to intervene in party politics, and the fact that until 1962 it continued to operate as a branch of the parent company in the UK, may have been additional factors in its apparent ready acceptance of a national health scheme. There was a further, probably more important fact, that the profession has always been governed by a code of ethics that has made it difficult to argue against free healthcare. This code casts doctors in the role of servants who are ethically obliged to care for the sick, irrespective of their character, the cause or nature of their illness, or their capacity to pay. Doctors are not meant to care about money. So that when the AMA calls for an increase in rebates or fees, it always claims that the increase sought is not to protect the financial interests of doctors, but so that the interests of patients can be protected. It's also difficult to argue against a state monopoly in healthcare delivery and for professional independence when medical professionals themselves have always been dependent on government to secure their own monopoly on service provision. Most doctors not only believe that the licensing system is actually beneficial to consumers, but they've always been indoctrinated with the view that the pursuit of individual self-interest is necessarily harmful to the interests of the whole, and that there's something special about the practice of medicine that makes it inappropriate to apply to it the kinds of values that are generally considered appropriate elsewhere. Patients are especially vulnerable, or so it is argued, in an unequal power situation and are highly dependent on trust, particularly in circumstances in which they may be dealing with complex questions, confused or even unconscious. According to the AMA, competition works in an adversarial rather than in a cooperative paradigm. Markets, says the AMA, derive their moral values purely from the pursuit of profits. They are devoid of charity or compassion, they threaten standards, and the self-interested behaviour of those working in them undermine the kind of trust that is necessary for an effective doctor-patient relationship. This lack of understanding about behaviour in markets has inevitably led to reliance on government to solve professional problems. As early as 1941, the AMA argued, and I quote, that the care of health is a social duty and not an individual responsibility. And in 1942, it joined in the almost universal support given to the Beveridge report recommending a national health service in Britain. When the first major clash between government and the professions occurred in 1944 with the introduction of legislation for the Pharmaceutical Benefit Scheme, the AMA did not disagree in principle with the prescription of free medicines, but only with the fact that it was government that would decide what medicines were free and that doctors would be required to use government-issued prescription pads. Similarly, the AMA offered no objection when the pension medical scheme was drawn up in 1949 or when subsidies were provided to private health funds. In fact, the AMA has always argued that government subsidies to health funds and lifetime community rating are the best way to promote universal health coverage. In the AMA's defence, however, there is little in the Australian Constitution to suggest any limitations on the authority of government. In particular, Section 651 lists the provision of pharmaceutical, sickness and hospital benefits and medical and dental services as being proper subjects for legislative control, with the only proviso being, but not so as to authorise any form of civil conscription. It was this proviso, therefore, that formed the basis for the profession's opposition to the plans of socialist governments. The AMA's argument was essentially limited to the claim that if a national taxpayer-funded scheme was to be introduced, it should be on a basis of fee for service, rather than a system of capitation or salaried service. But the idea that doctors could continue to charge whatever fees they liked on a fee for service basis was bound to come into conflict with a taxpayer-funded scheme in which government needed to predict and control all its costs. It was simply never going to be possible for the profession to secure the economic freedoms associated with markets in a system run by government. Nevertheless, as part of its strategic approach in the 1960s and 1970s, the AMA was prepared to do almost anything to appease coalition governments who were attempting to offer the electorate an insurance-based health scheme that compared favourably with Labor's proposed taxation-based scheme. The AMA supported, therefore, the introduction of a list of most common fees, which it felt it should be applied countrywide, and it was prepared to negotiate with government to determine the level of the fees and to encourage adherence to them. Most seriously, the AMA, which at that time was heavily dominated, at least at committee level, by specialists, also supported the award of higher rebates to specialists for the same service as when compared to the same service performed by general practitioners. This required the creation of a list of recognised specialists and a referral system. All these measures provided some of the essential groundwork for the later introduction of Labor's scheme. They also led to the creation of the General Practitioner Society of Australia in 1968, now called Private Doctors of Australia, and the organisation that I represent. The differential rebate, the systematic exclusion of general practitioners from public hospitals, and later from the provision of pathology and X-ray services, were all critical factors leading to the de-skilling of GPs, increasing the number of specialists and raising the costs of services and limiting access to them in many areas. The GPSA, which at the time had a membership of around 20 to 30% of practising GPs, was a much more market-oriented organisation than the AMA and provided a much more vigorous and principled opposition to the introduction of a taxpayer-funded scheme. Strategically, it promoted the view that doctors could be protected from the effects of Labor's scheme by staying well clear of government money. It encouraged doctors to run cash practices, provide item numbers only on receipts, to refuse payments from third parties, and to withdraw from government subsidised schemes like the pension and medical service. It also refused to negotiate with government about anything, only to report the views of its members. While some of the GPSA's aggression rubbed off on the AMA continued on its negotiating way, often fearful of what government might do if it refused to comply. And when the negotiations on a particular issue were over, the AMA typically counted the concessions given by government as great victories and discounted the losses as unavoidable, while government always inched a little closer to its goals. Finally, the threat to introduce a taxpayer-funded scheme became a reality with the election of the Whitlam government in 1972. After some modifications to the original proposals, which incidentally included the total exclusion of private insurance, and despite an extensive political and public campaign launched by the medical profession, the funds and the private hospital sector, Medibank commenced operations in July 1975. Shortly thereafter, when the coalition won office with one of the largest majorities in history, there followed a series of policy changes that did little to alter the fact that government was now irreversibly, extensively involved in the delivery of healthcare. Then in 1983, the Hawke government was elected, and Medicare, which was essentially Medibank reborn, received assent in December of the same year. Arguably, those in favour of free markets in medicine were never going to be able to prevent the introduction of a taxpayer-funded health scheme. The constitutional constraints on conscripting doctors and the practical difficulties inherent in any free scheme were never going to get in the way of the ideologically committed or of those who saw the political gains to be made by giving away health care at bargain prices. Liberal politicians generally opposed Labor's scheme only when it was politically safe to do so. The press was hostile, trade unions threatened dissenting doctors, and of course there were always a considerable number of doctors who were either sympathetic to Labor's scheme or derived some personal or organisational benefit from supporting elements of it. The Royal Australian College of General Practitioners, for example, was never going to jeopardise the millions of taxpayers' dollars it's received for its training program by opposing government's proposals. In my own view, the great failure of the medical profession has not been so much in preventing the introduction of a national taxpayer-funded health scheme, but in facilitating its subsequent survival and extension. After initially adopting the never give in, never never approach of the early Murray Rothbard, I later came to believe that the most appropriate response to the presence of a free health scheme was to follow the advice of the later Rothbard, in which he suggested that to insist on declining any government largesse is to confuse dealing with a situation that you did not create with contributing to the worsening of it. That little good and great harm may accrue to the individual who feels that it is his responsibility alone to cure the ills of the world, and that you can be only obliged to do what can be done. It seemed to me that at least after 1983, it was acceptable for a physician to direct bill for patient care, provided the physician continued to point out the evils of the system and did what he could to oppose it. Rothbard made the further distinction that while private employment is to be preferred, government employment is acceptable, since there may be few alternatives in some situations, provided that the physician did not involve one that would not exist in a free economy. Similarly, lobbying may be acceptable, said Rothbard, if the aim is to protect oneself against the lobbying actions of others, but unacceptable if it means initiating any new rent-seeking behaviour. While the choice between these two different approaches resulted in some bitter and lasting recriminations, the vast majority of doctors adopted an entirely different strategy. The AMA in particular was only too willing to go along to get along, to lend a helping hand when cracks and crevices appeared in the structure that government had insisted on erecting. While claiming to defend confidentiality and autonomy in the doctor-patient relationship, for example, the AMA has supported dozens of interventions that have enabled government to monitor and interfere in that relationship. It was also heavily involved in the creation of professional service review committees, and it happily provided and continues to provide members to sit on committees of inquiry and a wide range of other government bodies. Particularly since the 1990s, when its official policy stance became constructive engagement with government, the AMA has assumed a political role as a lobby group intent on obtaining a fair share of the spoils for its members. If anything goes wrong, it invariably turns to government to fund a solution. It now spends a great deal of its time lobbying government about social issues, mental and Indigenous health, unemployment, substance abuse, sexual diversity, the health effects of climate change, and better health care for asylum seekers and refugees. and it almost invariably adopts a perspective sympathetic to the views of the left. And it is the AMA that is the most vociferous supporter of the many attacks on free choice and personal responsibilities that are associated with the collectivist concept of public health. According to the AMA, and I quote, "Every adverse health effect should have its matching regulatory control." Of course, it's not only the AMA that has decided that the best way forward is to embrace the socialist methodology. The College of General Practitioners has also demonstrated on several occasions its preparedness to utilise the power of government to pursue its organisational goals. And similarly, the Rural Doctors of Australia have always been in the forefront of calls for taxpayer-funded handouts called rural incentives, and for coercive measures to provide doctors to rural areas. To some extent, the profession has always been a home for paternalists, and the AMA has always been a left-of-centre political organisation. But we now have a generation of medical practitioners that have no experience of practice before the introduction of a taxpayer-funded scheme. The interview process for medical school entry that looks for empathy and altruism, the decreased acceptability of holding and expressing contrary views at university, and an increase in the number of bureaucratic and academic positions open to doctors are some of the factors that have led to an increased flow into the profession of graduates who are sympathetic to the centralised control of healthcare and actually approve of the core features of the system in which they are now required to practice. These are the people who in academic, organisational and committee roles actively assist government in progressing the socialist vision for the profession. Now that the National Health Scheme is a fait accompli, even some of the older age group have discovered reasons to like the new system. They have no bad debts, they don't have to compete so hard for patients, they don't have to worry much about doing house calls, and they've done quite well financially, since, as we know, most of the benefits of the welfare state go to the service providers rather than to the poor. And the fact that doctors' fees are guaranteed relieves them of the difficulty of distinguishing between the worthy and unworthy poor, and of being personally responsible for funding their charitable decisions. It's much easier to fall into step with the view that access to healthcare is a right if that right must be serviced by government rather than by the individual practitioner. And as is the case with all other kinds of government giving, the pseudo-charity of the state funded by coercive taxation is considered the moral equivalent of individual voluntary charitable acts. Most doctors also like the idea of a centralised system that protects people from harm by using the power of the state to limit their choices. Ironically, as a necessary accompaniment of their acceptance of a centralised delivery service, doctors have had to accept the dismantling of features of their ethical codes that they had previously considered an integral part of what has been called the internal morality of the profession. They are now required to acknowledge, for example, the state's financial interest in the doctor-patient relationship, doing away with strict standards of patient confidentiality, performing tasks for which the state rather than the patient is prepared to pay, and risking patient welfare by engaging in cost-cutting measures like early discharge and fund-holding schemes. And while the service obligations of the profession have now been enshrined in medical practice acts, so you can't get away from them, their licensing protections have been gradually eroded by governments intent on opening up what they euphemistically call the market to selected alternative providers. Predictably, governments are also getting progressively closer to gaining complete control over fees, without, as Gough Whitlam predicted, having to worry about any constitutional constraints. Large numbers of patients are already being managed beyond the system of fee-for-service, and more are regularly added. The profession has embraced, for example, a system of block funding that rewards practices for tasks determined by government, and it has accepted an increased role for fund holding, in which the healthcare needs of a defined group of consumers are managed through access to a pool of funds. So what are the prospects for reform? Obviously, the usual reasons given for reform are rising costs in the face of deteriorating quality. But of course, costs will always be a problem in a system in which politicians driven by interest groups and electoral opportunism can shower taxpayer money on whatever project takes their political fancy. When most hospitals are run by governments for the benefit of the unions that staff them, when there is little incentive for the participants in any exchange to limit supply or demand or to keep the transaction honest, when a large bureaucratic apparatus is required to monitor both patients and doctors, and when government must oversee and control anything in the system that might conceivably impact on costs. And while health professionals and politicians will deny that the quality of care is in decline, it is clear that there is a shortage of doctors and nurses, that there's been erosion of the skills base of most GPs, that infrastructure is inadequate, and that in an increasing number of instances, the genuinely ill can no longer gain timely access to appropriate treatment. And when they do, they'd better be very careful of the sort of advice they accept. At least 10% of admissions to acute care hospitals are now associated with healthcare related harm, as are over 1 million general practice consultations each year. The greatest threat to quality, however, is rapidly becoming the budgetary constraints that restrict access by patients to the best available treatments. Unsurprisingly, the reform process generally involves trying to reintroduce into the centralised delivery system some of the features that are characteristic of markets. In the latest round of reforms, this has meant trying to tighten the link between payment and performance for both doctors and hospitals. The public has also been promised more information about the performance of hospitals and that the system will be made more responsive to their needs. However, payment for performance in a centralised system still means that what is paid and the performance that is rewarded are determined by government. And a system based on the welfare of the collective simply cannot be responsible to individual consumers. From the public health perspective, what is important is the total number of people who, for example, are obese or smoke, not the risk-benefit analysis for the individual. Similarly, it attempts to bring the decision-making process closer to the patient by introducing, for example, fund-holding schemes, are often more accurately identified as attempts to move more patients beyond the system of fee-for-service and to shift the blame for rationing decisions away from government. Competitive principles to lower costs and increase quality can never be effectively introduced into a system in which competition, the pursuit of self-interest, and the outcomes achieved in markets are considered to be undesirable. The equalitarian principle underlying free healthcare is that nobody should receive a level of care that is not equally available to everybody else. But we really can't have individuals and institutions trying to demonstrate that they are better than other institutions and individuals. And what is the point of providing more and better information to consumers if consumer choice is not to be encouraged and respected? There's no point in identifying a good hospital or a good doctor if you're compelled to attend a particular hospital or doctor on geographic grounds or because you are part of a capitation scheme. And there's much less incentive, of course, to locate a quality provider at a good price when the consumer is not responsible for paying the full fee. Clearly, therefore, nothing much will change as a result of reforms that don't challenge the underlying philosophical and economic basis of the existing system. Prospects for the future, therefore, appear bleak. Politicians and bureaucrats are generally reluctant to let go any of the power they have accrued, and citizens continue to believe that there are innumerable free lunches to be had through the political process. People also believe that without the state, worthwhile causes will not attract support, the deserving poor will be left to fend for themselves, and the ignorant will be able to make choices that will cause them great harm. Consumers may be aware of the presence of extensive waiting lists for medical care and often hear about the unnecessary and increasingly common adverse events that occur in public facilities, but they don't understand how care is actually rationed, how private insurers are prevented from offering a full range of products, how much money is being wasted, or how they would fare under different arrangements. They have no experience of any alternative system, and they believe that all is required is some fine-tuning of the current system. On the other hand, medical practitioners are unlikely to abandon the faulty ethical codes that make it difficult for them to question the philosophical basis for the current system. Indeed, to suggest to medical practitioners that their ethical views may be wrong is often interpreted as an attack on the identity, or at least on the professional identity, of those who hold them. For these reasons, I think that things will get a lot worse before they get any better. Healthcare is the field in which the welfare state is probably most firmly entrenched and will be most resistant to change. And while there are a number of things that could be done to move us in a different direction, we're not likely to see a return to free markets in medicine without a much wider winding back of the welfare state elsewhere. Thank you.
There's time for maybe one or two questions.
Hello, my name's Aaron Litterman. My question is, with, I suppose, a free lunch, i.e., oh, don't worry, we're going to give you free healthcare and somebody else will pay for it, they then can say, well, to contain costs, I then have to restrict you having, say, a hamburger, a cigarette, a glass of wine, some energy drinks are acceptable, some aren't, whatever it may be. And I have a right as a government to tell you that because, on the other hand, I'm paying for you if you get hurt, or I'm paying for you. So do you see that kind of come into the picture with the AMA sort of supporting a strict lifestyle in whatever they see that to be?
Yes. I think it's a very real problem that ethical codes now require you to take some notice of the cost of your patient's behaviour. It also is a factor in relation to increased attacks on doctors when you tell patients they're not entitled to this particular service, or that they should perform, that they shouldn't drink or they shouldn't smoke, that you enter into their lives and there's too much haranguing of patients rather than just giving them the advice that it perhaps is not best for you not to smoke or drink. Now you're expected to ram it down somebody's throat because other people are paying for it, and that, of course, is a problem. We do pay for other people's bad habits, and we shouldn't have to. That goes back to the fact that we shouldn't have a free health system. You don't attack it that way. You make people responsible for the payment of their own illnesses, and you're not faced with that problem.
Thank you, Dr. Bedkober. Christopher Horn is my name. I work in health as well, and I find I'm astounded at the deeply entrenched attitudes regarding, right to free healthcare and this sort of thing. And it's a daily sort of, conversation I have with my colleagues. But I wanted to know, do you see, I guess, some weak points where moves might be made towards more free market reforms, or do you think it's just going to be the constant grind while public health continues to run the other direction of intervention and more socialisation and that sort of thing? Do you have any sort of see any plan the way forward to open this up? Or?
Well, obviously making people responsible for the small fees that they paid would be a very important thing. Right? One of the big problems with the ageing population now is that we may be very encouraged to move away from this system because the costs of it are going to be absolutely astronomical with the ageing population. 85%, I think, of the healthcare costs of any individual are spent in the last 2 years of their life. And in the US, I think 25% of Medicare costs are borne by 5 to 6 of enrollees who die within 1 year of having made the expenditure. So that there may be some very good reasons why government just simply can't afford the current system, and there are some. But on the other hand, their reaction to that is to introduce fund holding schemes and early discharge schemes and try to control costs. They're not letting go of any power.
But oncoming crises may actually provide opportunity to...
Sorry?
But potentially oncoming financial crises when it comes to this, and so may provide opportunities to act.
Sure, but look at Europe and look at the US. You know, why did Obama get re-elected? You know, there's something really bad has got to happen.
Do you have any view about the roles of the learned colleges and sort of as gateholders into the profession? It seems to me that that's just a...
Well, yes. Well, I'm opposed to the system of licensing. Government licensing in the market system is a different issue, and yes, the role of specialist colleges in limiting numbers of people coming into specialists. This is a cost measure for government, right? They're holding down numbers because they see doctors as cost generators as well. But when the ACCC expressed some interest in the role of medical colleges in restricting entry to their particular specialties, the AMA became more vociferous and about markets and very critical of the role of markets in medicine, and had no role to play, rather than criticise the role of the colleges. So yes, well, you know, they're all the same, and they don't want competition from general practitioners. Don't want competition from allied health care providers either. But government is opening up that whole area because they see it as being possibly cheaper. It's not, probably. I'm not sure if I answered your question. No.
Maybe one more question and then lunchtime.
You're fairly pessimistic about making any progress on this, and it seems to me that the way to make some progress would be to perhaps propose an alternative that might not be too appalling for a lot of people to accept. So 2 suggestions that float around at various times are health vouchers, and the other one is a loan scheme like HEX, that sort of thing. Not entirely sure how the loan scheme would work when you died, but I'm not into practical details. Have you contemplated those or any other solutions, if you like, that might actually get us out of this current bind?
Well, I'm not a fan of voucher schemes, generally speaking, because you have to take money from taxpayers in order to make a voucher. So I've never been in favour of that sort of idea. Well, I know Milton Friedman was a big fan. But I think that it's important for the medical profession to stop whinging about it when rebates fall below what they consider to be acceptable levels. One easy way out would be to let rebates fall progressively lower and lower, and patients have to pay an increasingly greater co-payment would be one way to go about it, but certainly reorganising insurance so that health savings accounts, previously called medical savings accounts, going in that direction I think is a good thing to do. I just don't see any of these things holding much water at the moment.
For the final question.
You just mentioned health savings accounts. I think that's a system similar to what Singapore has.
Yes.
Any commentaries on how effective you think that system has been?
Well, health savings accounts are very good things if they can work. The idea is it works on the principle of having a high deductible, as you probably know, and therefore your premium for your health insurance is very low. Like in car insurance, I think if you have a high deductible, it lowers the size of your premium by by 30 to 70%. Well, if you have a high deductible with your health insurance, it also lowers your premium by a similar amount. I think it's around 60%, they say. And the idea is that you use the money you've saved from paying for your health insurance to pay your low-cost events, so that you, instead of paying an insurance of $3,000 a year, you pay $1,000 a year, you put the $2,000 into an account, and you use that account to pay for your GP consultations at $25 or $30 each time you go, so that you'll build up an amount of money on the side to pay for other things when they occur. And I think there's a couple of states in the US where they're permissible, but they're not permissible. In fact, Private Doctors of Australia had their own HSA account many, many years ago, which went out of business more or less. But not because it was financially ineffective, but just a lack of interest. But yes, I think that they're good things to do. I mean, it's a very complex issue.
Thank you very much. It's now lunchtime. Please be careful with the crockery.